those handsome young men. All right. So, neurotrophic keratitis. We're going to show you the typical, what do you call that? You guys know. Treacherous. Yeah. We're going to show all kinds of stuff here. Okay. There we go. So this is the not growing enough lecture. So neurotrophic keratitis, of course, you have a denervated cornea. You're not just losing your protection, your blink reflex, your tearing reflex. You're also losing your production, the trophic factors from the nerve that tells stem cells to grow. And the symptoms, you get bad epi, you get bad vision, but no pain. You don't feel it. You don't feel the defect. You don't feel the SPK. Exam, early on, you might have rose bangle staining. I mainly use fluorescein. And the thing is, you can often get delayed staining. So remember, when your epicells are sick or you have abnormal epicells, they often stain late. And the cells can be gray. Why would they be gray? That's kind of weird. Late exam findings, you'll get like the all-out epi defect, and the edges are just rolled, kind of like, looks like split ends, gray split sickly cells. And it's usually going to have the shape that's oval and slightly inferiorly displaced at the center. We're gonna nail that into your brain as to why. It can certainly progress to prominent staining before it becomes a all-out epi defect. But here's an example of gray epithelial cells from neurotrophic keratitis. And they're just, towards the middle it gets gray. It's usually not on the edges. Why? Why is it gray in the middle and not on the edges? And why is my computer not working? Oh my gosh. I'll have to edit this out of the video. There it goes. Okay, it's just moving quickly now. All right. So, from epi defect to this big old classic oval defect. We're going to show you why. The treatment is elucidated by the exam features in some degree. I'll show you what I mean. Why is it displaced in more wide inferior and more wide horizontally? Let's measure the growth arcs. It looks like it's growing further superior than it is from the other locations, like a longer distance. Why is that? And we're going to show you on this picture, a random eyeball for you. What is special about the upper cornea? The upper cornea is covered more, protected more, less exposed. The bottom is the most exposed. And maybe why is it more wide horizontal? Well, it's the longest pathway. Corneas are wider horizontally. It's basically, it's telling us that the cells aren't able to journey as far as they normally can. And they can journey further if you protect them, though. If you protect them, they will journey farther onto the cornea before turning gray and dying. So it's grayed rolled edges of cells. So why are they having trouble running across this cornea? There's a great example of the rolled edges of an epithelial defect. Gray cells at the edges, showing you the sequelae. If the cornea can't protect or control its microenvironment, it can get all abnormal and break down and scar. Why are they gray? So the epithelial cells are really super runners. Like, this is a sheet of cells has to grow from its blood supply, store all of its energy with it, and take it to the middle cornea. It's an amazing run that those cells make. So what's wrong with these cells? I mean, I don't want to take anything away from them. I think they're still super runners. It's just that in neurotrophic keratitis, they're getting a little bit old. Nothing to be taken away from these guys, but they're getting a little bit old and gray. Well, sometimes you can be young and gray, right? So on histology, you might see that they have reduced They're getting thin and sickly, and they have depleted glycogen. Remember, they just got to take their energy from the limbus and bring it all the way. So they're getting old, out of energy, and they're breaking down. These runners are not being replaced fast enough. They're getting old. They're just sitting there waiting for the replacement to come, and it's not coming. So they're getting old and gray. That is beating it into your head, isn't it? Yeah. Okay. So that's a little mnemonic for you. And test the sensation. So if you ever see a patient like this, before you put any numbing drops in, you'll really nail it by take a little cotton tip or something, just touch each quadrant, compare it to the normal eye or to what you think a normal eye should be. If you touch an eye, it should blink immediately, not like, oh, I sort of feel that. Grade it 1 to 4, and old gray hair with split ends. There's your mnemonic. So you guys can look at those questions and let us know if you have questions on the questions, but they're probably self-explanatory. I think all of your test material should just come from the questions, because we're just trying to have fun with this lecture. The treatment, as we alluded, treat any underlying condition, of course, but you want to protect these cells, baby them, because you're asking them to journey longer than they usually do. They're usually replaced weekly. They might be not replaced for 3 whole weeks at this rate. So lubricate the surface, all those types of ointment and lubricating treatments. You want to protect them from exposure and friction. So that's going to be the contact. No more friction from the blinking. Tarsorrhaphy will reduce the rubbing, but also it'll slow your evaporative eye drying. Holds on to tears longer. They depart slower. And then you want to nourish these cells. They're running out of glycogen. So serum tears can help. Amniotic membranes, sutured or Procara, can provide some extra nutrients, maybe to keep these cells going. Oxervate can help you grow new ones, but it's real expensive, as we said. We like to use that as a last resort because of, whoa, I heard 80,000 recently, but yeah, it's up there. But then at some point you got to do damage control. It's like, I got a frank epi defect and I cannot get it to heal. So damage control is going to be heal the epithelium, but if you can't slow the collagenolysis, which is vitamin C doxycycline, and maybe just let's give them a new epithelial. Hey Susan, I want to lecture, but maybe just give them a new epithelial barrier by bringing the conj over. Now that'll stop the melting. And if you feel like we're losing this battle, or you've already lost that battle, then you're talking PK. You can't just sew. It's like sewing a tire together. You got a big hole in the middle. You need a new one. Questions, anybody? Okay, let's talk about etiology. I'm a pictorial person, so let's just look at the course of CN5. It starts in the brainstem, comes out in the space, entering the orbit there, goes through the orbit, after first going through the cavernous sinus, and then it's going to enter the eyeball. It's an intraconal structure, and when it enters the eyeball, it travels along the long ciliary nerve, and then goes across the cornea. So anywhere in that pathway, you can mess up cranial nerve 5. And you guys can read all this list, but we're just going to illustrate a few important concepts. So all very common things that can get your cranial nerve 5. So let's talk about the central nervous system. A schwannoma is very important because it's a double threat. Why is it a double threat, Ian? Often a double threat.
I don't know if I know what you mean.
So a lot of times those brainstem schwannomas and tumors, it comes out real close to cranial nerve 7. So the part of the blink reflex, I can feel irritation. Now I want to blink. You take away your, stimulus to blink, but then you take away your ability to blink. You're not even going to get a protective Bell's phenomenon because those muscles don't work, and you're not getting driven to blink. So
you're neurotrophic and exposed.
Yes.
I understand.
Yep. So if you have at least one, if your cranial 7 is out, but at least you feel pain, you're tearing and rolling your eyes back in your head, or vice versa. If you can't feel it, at least you're blinking some.
Yeah, that's a good point.
Take out both, it is a double whammy. Another double whammy is going to be the synergy of diabetes. So, panretinal photocoagulation often irritates these nerves, some, and they're already sick just from systemic disease in diabetics. Their nerves are bad all over the place. So you get a double whammy, and we'll show you a case of that where you're like, yeah, that looks like a double whammy. Here he is. So this 50-year-old guy had horrible diabetes. If you guys want to make me super happy, subscribe to my YouTube channel, Lawrence Tankman. That's the eye ninja, but you have to type Lawrence Tankman or else it thinks you're looking for a YouTuber who plays Fortnite. Anyway, this is from the Lock and Load Injection for Infection lecture. Cool lecture, but he's the last case. Amputee who has kidney disease, and he, years ago, had PRP extensively and vitrectomies for PDR and tractional retinal detachments, OU. And he actually has like a diabetic cornea. His ischemia is so bad that he had a neovascular membrane going into his cornea. What do you think his retinas are going to look like? Right eye's blind, by the way, has no hope of vision. Left eye, he's been hand motioned for years. And he had these surgeries years ago before his cornea went bad. I'm like, you don't have any hope. What's that? Somehow he talked me into doing a PK, and he was 2150. He didn't have an epi defect day one because the donor epi didn't shed yet. And like, oh my God, we had that lecture about how the edges can swell and you're not seeing that well at the beginning, but you're already 2150. You might have some potential. Day 4, host epi sheds. And then he gets edematous. Why does he get edematous? Because his tears have no barrier to rush into the cornea and make it swell. Now he's count fingers. Day 7, no change. And we give him a Procara Plus for 2 weeks. No change. I'm trying to nurture this epi. Let's go, epi. I give him a tarsorrhaphy. Remember, the epithelial cells really don't want to be exposed, and they really don't want friction because they're trying to last. And we put a tarsorrhaphy in, boom. Exactly in the areas where the tarsorrhaphy is present, epi regrows. And exactly in the areas where it's exposed, cells shed and die. Or shed. It's week 6, no change. All this inflammation is pissing off the immune system. There's KPs on the donor. What should we do? Let's do more of what's working. Give him a full tarsorrhaphy. Contact under there and just protect. Week 7, 2 weeks, so he's at week 8, and he's like, my primary care doctor pried open my eye.
What a call, though, Larry. I don't mean to interrupt. What a call, though. He's got a blind right eye, and now we've sutured his good eye shut, right? I mean, how did that conversation go?
It was hard. And this guy's has issues mentally, so he doesn't understand things well. But he kept it in for 2 weeks, and he pried it open. And, of course, it started to break down. But it's like, can I just keep him shut forever? Do these nerves regrow? Like, what's our end game here? But clearly his diabetic processes stopped getting worse because he didn't know he had diabetes. He was a blood sugar of 550. And then as soon as he found out that all his stuff was bad, and lost his kidney and his knee and part of his eye, he's been like perfect on his blood sugar. So as long as they stop having bad sugars, you can make a defect or you can make an improvement. We closed him again with much counseling, and we went for a whole month and he was healed. And then started to open it a little bit, and dang it if it didn't start to break down again. And placed a contact falls out. I mean, this is just going on forever. We keep on trying to protect, and this story goes way beyond what we have here. Like, we're getting out to month 5, same stuff. Month 5.5, he actually healed and was 2200. That's just the tip of the iceberg of this story. It went round and around on lock and load, injection for corneal infection, but we came up with the treatment that was also someone else devised, where we're doing a prosthetic cornea with a Gunderson flap. I don't want to give too much away, but the result that Ninja K Pro and the end of lock and load injection for infection is this treatment. Both patients are out like beyond 5 years, and they have the same result that they have now is what they had at the end of the videos on YouTube. If you guys have time to watch those, I won't spoil it. Okay, so there's synergy of diabetes. I'll say that was awful. Like that epithelium was never going to stay stable. The most common is viral keratitis, herpes family, simplex and zoster. Oh my God. That's like, remember how we said, I wonder if the nerves get sick? Is that also why people get diabetic foot disease? Like you're not getting trophic factors to tell the skin stem cells to grow? Is that going on here maybe? I mean,
sweet mother of God.
I know, Chris. For those of you who don't know, that's Chris Farley. Yeah, that skin looks dead. And oh my gosh, that cornea. Whew. Let's leave that one alone for now. All right. But yeah, zoster. Who all has nerve problems from zoster ophthalmicus? About 20% will in the acute disease. And 50% within a year eventually will get it. And it gets better a lot of times, but not always. I mean, a third, it just lasts beyond a year and it's hard. PK patients often will get a little trouble with the nerves because you're cutting all the nerves 360, but there's still some nerves existing where the stem cells live. But so they still can grow. Anecrotic keratitis, though, can cause neurotrophic keratitis. So inflammation is not good for the cornea and its nerves. So cicatricial conjunctivitis, those diseases, and topical medication toxicity can sometimes do it, anesthetic abuse, or just a persistent epithelial defect. Remember, to maintain its microenvironment, the cornea likes to have intact surfaces on the front and back. If you break those down, it can lead to trouble. What about recurrent corneal erosions that heal too slowly? This is an interesting case. This guy's had RCE for years, and they would always heal. In a few days. He is a classic RCE patient, but since RCE's been getting a little bit worse this past winter, his eyes are a little drier and tackier, more friction, and just getting worse as winter approaches. And he's 20/70. And other doctors have seen him and says, yeah, you got this diffuse keratitis. It's kind of weird. Contact lens associated, maybe. I don't know. You're only 20/70. You used to be 20 plus. Lotemax isn't really helping. I mean, he comes back 4 days after this blurriness, and he's got a defect that's horizontally wider, maybe slightly displaced inferiorly. We check sensation. It's quite low. So it's like, this is a neurotrophic ulcer, guys. So you baby the epithelium with a lot of the stuff we do, prevent a bacterial infection meanwhile. And we're at a week later and he's got, this dysplastic, gray, weird looking epithelium. But now you guys know why it's gray. See, we might not have been thinking straight there that's just, yeah, of course, you're neurotrophic. You're not replacing your cells. They're gray, they're old. 2 weeks after onset, he's just vision's fluctuating, 2200, 2100. At a month, now we're 2 months. Still has this gray epithelium, 1 to 2 plus. 2060, hey, we're getting better. Now we're almost 4 months, 2100. Like, it's just pivoting back and forth. This guy's erosions used to be something that would just come and go in a matter of days. This guy's in a tailspin for 4 months, almost 6 months, and finally, he's getting to the point that he's starting to get some sensation back on that left cornea, just on the bottom. He has this gray cells still growing in. 2050. At some point, we decided to give him I don't know if I wrote the Procara to try to nourish the cells, and it actually finally made a difference. There it is. So he's over half a year just going back and forth. This is going to go on forever. He's losing vision again, and then, hey, 2020, all right. That's almost 8 months after the onset, and he's got full sensation. So his epidefect was healed for a really long time. The message is, what we think's going on is, how long does it take nerves to heal? Well, maybe it takes a while, but they can't heal if the epithelial defect keeps coming back. But you got to keep it healed, and it can take a while. And if the nerves heal, this guy's been back to normal. 10 months, he still looks good. I want to tell you, at 7 years, he still looks good. So this lecture's been going on for a while. He's at 6 or 7 years now. Questions on that? Okay, now we talked about treatment. You want to baby the epithelium. You want to try to nourish the cells. Sometimes you got to do desperation treatment to try to prevent breakdown. So this guy had a fungal keratitis. Fungal keratitis counts as any kind of chronic keratitis. His cornea was thinning. It was all from shrubbery. You can see this iPhone photo. There's little feathery margins. We have really good pictures on our infectious lecture if we ever give that to you guys. A little bit of satellite. You can see all the stuff on retro illumination and para illumination because it bounces off the back and lights up the back. Yeah, those little feathery guys there. But it starts suddenly rapidly thinning. I mean, he was stable, but he goes to 80% thin all of a sudden. And now we're going to use the epi of the conj to help us out. So this is a partial flap. You can see on the left side, we pulled this flap 2/3 across his cornea. There where these little black sutures are, is where it was anchored. It's actually kind of breaking through the sutures and going back. The tension will actually pull these flaps all the way back to where they live, and they'll just adhere back down at the limbus. It's crazy. But meanwhile, while these flaps are over top of the infectious area, one, they provide an epithelial protective layer to block further collagenylysis. Two, they provide blood flow, which gives you white blood cells to help kill infection, as well as any oral antibiotic is now delivered. So you can just take oral medicine for the cornea. And as it retracts, doesn't want to stick to intact epithelial cells. It's going to stick to bare exposed stroma. But look what it's doing. As it retracts further and further, it basically persists as an iatrogenic pterygium, protecting that area for the long haul. Isn't that amazing? And this is his better seeing eye now. So that's a great use of that trick. Here's a severe dry eye patient. Dry forever. Gets, you know what kind of defect that is. That's a neurotrophic defect, and that's what she was. And it's all caused by dry eye. And she was chronic keratitis for so long. Look at the overlay of the flap that I gave her. We put a flap over that spot, and it retracted, and it kept this little finger where her epithelial defect was, which fortunately wasn't blocking her pupil. She was seeing great, and then the whole thing stopped. Those are desperation cases, but man, sometimes you got to get creative to try to help these people. And as you know, the prognosis, sequelae, we were talking, can the nerves regrow? The answer is yes, but not for CNS lesions. If it's a peripheral lesion, it can. This little study kind of talks about the rate at which they regrow in micrometers. But if you do a little math, it's basically saying that for these peripheral lesions, if the epithelium is intact and stays intact for a long time, the nerves can regrow. They might go back to normal. It's a little slower for diabetics. And yeah, it's slow, especially for diabetics. So we'll skip past these questions. All right, so other sequelae though, in prognosis discussion is what happens if the epithelium doesn't heal. You guys know this. I mean, it's scarring. It can't maintain its microenvironment. It can thin, and it can eventually... Chris, what are you doing, man? I don't know. Chris, I don't want to talk about this one, Chris. Oh yeah, this case. Sequelae. Perforate. Let's look at this cornea. Is it gonna... Oh, man.
Sweet mother of God! Good Lord!
I agree, Chris. That's a full corneal ulcer. The whole thing's an ulcer, and the iris is plugging this huge spot in the middle. I'll tell you what, the people who cherry pick LASIK and cataracts would never take something like this on for one of your patients. But basically, the largest hospital tree find could not cut away the infection. So we go all the way around. The lighting's not the best, but trust me, after I sew this donor in, it's white with infection on this whole rim. So what are we gonna do? This is also in lock and load injection for corneal infection. And I'm happy to tell you that we have as long as you give the proper antibiotic, that it's not something resistant to it, this is an undefeated treatment in about 24, 25 cases, whether it's rim 360 infected, active infected, or big old ulcers that you got to inject with antibiotic and swell the leak shut because it's a perforated ulcer. we've killed all these infections like where they stand. And we did that for this one. You can watch it on lock and load if you want to see what happened. And anyway, we did that for her. She healed. I gave her a permanent tarsorrhaphy because I'm never going to want that to open up because you need extra protection. But she was doing great. Her cornea was lasting. She had a little bit of sneaky to her lens in there from all the inflammation. But here she is a year later, still thriving. Can you feel that?
Mm-hmm.
Can you feel that?
I can feel the pressure, yeah.
What if I just touch? Can you feel that?
No.
That basically means those nerves are never regrowing. So we can never let our guard down. That's a permanent tarsorrhaphy. What else does she need forever, Ian? Because she's spontaneously infected.
Antibiotics.
Attaboy. Antibiotics forever. Anyone who, K-pros can infect, they need antibiotics forever. Anyone who just infects out of the blue is someone who can infect. So they need antibiotics forever. And she actually hit 2040. She was 2200 uncorrected. And then with an RGP, hit 2040, which was pretty good for what she's been through. After 3 years, she spontaneously reinfected massively, despite lifelong antibiotics. So we had to do what are we going to do? Gunderson flap. New cornea first, and then just shut the door. You got one eye in the bank. Because I don't want to get on this playground again, this merry-go-round again. You guys can read the summary points. Okay, we want to do one more about cells not growing enough before we talk about glaucoma tonight. Okay, here we go. So where are the stem cells? We all know that these are pluripotent cells that live in the limbus at the corneoscleral junction, the palisades of Vogt. Their daughter cells can migrate across the cornea. Some of them retain a little bit of regenerative capability as they go, which is why epi ingrowth can fatten out and get these cystic structures. Usually the growth takes a week to get to the center, and then the replacements come and they are pushed off and they shed. Here's a question. Why must epithelial cells, when they grow not in hairs but in sheets from the limbus, why must those sheets be so loose? Why do they grow from the limbus? Why don't they just grow from the middle of the cornea, like skin? Then you can be real tough and not be prone to these erosions. And of course, the answer is you need a blood supply to grow. And if your blood supply was right in the middle of the cornea, you couldn't see. So you have to be loose enough to grow from the periphery where your blood supply is, or else you can't slide and glide. And of course, biology tends to occur as a bell curve. So there's going to be some who are less loose than others, and they're the ones who get the erosions. But it has to be loose enough to spread from its blood supply. And of course, what is epithelial stem cell deficiency? You don't have enough of these cells. But what happens is there's no longer the contact inhibition with the epithelial conjunctiva cells. And you will get conj epi growing across the cornea to fill in the gaps. Now, this is not the same as a pterygium. Pterygium is this odd growth where tenons and all the layers up to the epithelium all grow and like scar into the corneal stroma. In this case, it's just that thin little gelatinous layer of cells. And what's so different about the conj epicells is they're also a gray epithelial cell. And they also let in late staining, kind of like neurotrophic keratitis. They don't have as tight of junctions. And unlike cornea epithelial cells, they don't tell blood vessels, hey, don't grow. They allow them to grow. So on exam, you're going to see this initially sectoral, but eventually diffuse area of gray swirled looking cells, maybe scotch tape looking lesions. They'll come from superiorly and almost always superiorly and then grow everywhere else. They'll have this late, iron filing splinter staining pattern. And if it's there long enough, you get neovascularization. And as we know, in diabetic, about to sneeze, in diabetic retinopathy, leaky blood vessels can give you, heart exudates and stuff that makes things abnormal and turn a cornea cloudy. So almost always start from the superior quadrant, and a biopsy would show conjunctival goblet cells, but I've never really done that. So here's what it can look like. Kind of hard to see the gray cells. I see the blood vessels growing in and a little bit of extra opacity with iris as a backdrop coming from these vessels, like they're leaking opaque things. But to see the epithelial cells, remember, even with the pupil as a backdrop, you want to make it extra dark and then really light up that cornea selectively. And look at this. We're going to make a little corneal montage. Look how obvious the abnormal cells are when you put in the stain and when you hold the light the right way. Let's look at the other eye in this patient. Boom. Boom. Cornea montage. So much for retina montage. I had to do this manually. And then there's the corresponding stain pattern. So, yeah, look at that. So that'll really, really make their vision cloudy if it reaches the center. But then you want to think, what causes this? I don't want it to get worse. If you run out of stem cells, the only way you can get a new one is a stem cell transplant. That's a big deal. So anyway, the staining can go around 360. It can cover the whole cornea. If it covers the whole cornea, you probably don't have any stem cells left. It's just conj epi growing in. The symptoms, differentiating point from neurotrophic keratitis, not only is the location of the opacity, but they're going to feel pain unless it's been there long enough. Wait, can these overlap? Chronic keratitis of any kind can cause neurotrophic keratitis because the unhealthy stroma leads to unhealthy nerves. And okay, but if they feel pain, you're going to think it's probably not neurotrophic. They often get photosensitive just because nearby inflammation causes nearby inflammation. And if the iris gets inflamed, you're photophobic. Every time the inflamed structure moves, it hurts. Sequelae, just like all these others, you get the scarring defect. Neovascularization can come from any chronic inflammation, really. But if it's really in the epithelial cells, it makes you wonder about this condition. If it's in the stroma, you think about autoimmune keratitis, interstitial keratitis. So let's talk about the etiology. It's mainly going to break down to genetics, minor and major injuries. So genetic conditions, people might just have lower cell counts to begin with. Some people have low endothelial cell counts. It's often a part of a syndrome like aniridia, but not always. Sometimes it's just you get it. And then if you take something that's a chronic insult, you might go over the edge. So, you're going to see the people who get the repeat chronic injury, they probably had something genetic too, some genetic weakness. And number one is the soft contact lens abuse or overuse. But, eye drop sensitivities, rosacea, trichiasis, it can onset after a surface treatment like ASA, chronic dry eyes. Any of these can really push someone over the edge. So you really want to minimize any chronic insults to people that have this condition. Don't swim underwater with your eyes open in chlorinated water, etc. And one of the studies that was interesting, it says, the 16 by 16 rule, it says the average patient who showed stem cell deficiency associated with soft contacts was wearing them for 16 years for 16 hours a day. I don't know, kind of helps me remember it because I thought about it, now it's stuck in my head. Major injuries is going to be something that's just crushing your your epithelial stem cells, but then you scar the surfaces, and the actual cicatricial surface does repeat injury over time to erode the rest of them. So if you catch them when they still have some stem cells, you want to make the surface better, treat any scarred surfaces with mucous membrane grafts, and take away these insults, treat the dry eye. The major injuries, of course, is going to be a chemical injury or an autoimmune disease like Steven Johnson's. Skip past those questions. Treatment, we're going to break it down to medical and surgical. Medical treatment, you want to treat the cause. Take away the cause, like we just alluded to on the other page. Nurture to surface. We've talked about all kinds of ways to nurture to surface. But wait a second. We usually talk about a soft contact to block friction. Here you got to be careful because if they are early stages of stem cell deficiency and they're just showing it at 12 o'clock, a contact lens is going to push them over the edge. So you actually have to withhold the contact. You might be treating some funky surface with a contact, but it's not going to get better or start getting better until you withhold the contact. And it might recover and it might not. So that's tricky. We do all the other nurturing things. They say vitamin A can be helpful. You can get that online, I think Amazon, high-low. It's worth a try. Maybe it helps, but it can take a while. How long does it take stem cells to repopulate or to ramp up production? I'm often going to reach for a sutured amniotic membrane. You can try a Procera too, but sutured are a little more effective, but anyone can put in a Procera, at least try it. Avoid irritants, so preservatives, dust, dryness, chlorinated water, swimming with your eyes open. And it can take a long time, like neurotrophic keratitis. Trying to grow crops in the desert is what it feels like. Here's a case. Patient had cataract surgery, and her uncorrected near vision wasn't what she wanted. She was going for monovision. So, well, hey, let's enhance that. You're not near enough. Do some ASA. Okay, you're looking like you got a little overcorrection there, 20/40, but let's keep this contact in because your surface looks a little irregular. Take out the contact. Your prescription's all over the place. Why is your surface so fluctuant? Put the contact back in. Comes back. Man, I think you're not getting any better. That's crazy. Let's take the contact out. And then we see this grayed epithelium, swirled pattern, staining just a touch dry. But we start to baby the surface with a few things. Treat concomitant irritants, eyelid blepharitis, and keep the contact out. Let's just keep it out. And then here we are at month 7. I mean, this has been going on for a while. And gained a little ground, a little bit less prescription, gained a line of vision. Keep the same plan going, no change a month later. Let's place a Procera. Another month later, okay, it's a little better. The epithelial stem cell deficiency findings are only in the upper and lower corneas now. The middle's looking better. Keep the Procera in, a Procera Plus can last a long time. Another few weeks, it's almost gone, the epithelium, and then all of a sudden, another week, and it's a normal cornea with uncorrected vision of 20/30. So remember, jacked up, unhealthy epithelial cells, conj epithelial cells growing in a state of epideficiency on the cornea, you'll have just, they are not normal. Look how much the conj epithelial cells mess up the refraction. And it takes a long time for them to go away. We alluded to medical treatments, and now let's talk surgical. So if you need new cells, wow, that's a big deal. You can take an autograft if your other eye's healthy. The advantage is you don't need to have immunosuppression like a kidney transplant patient. But this is only for unilateral major injury. Like if you chemical burn, roasted one side, and there's almost no cells left, but the other side is completely normal. You're going to take from that side. If you have asymmetric genetic disease, I wouldn't mess with it. If you have asymmetric, soft contact lens sensitivity, I wouldn't take the cells from the other side, because in those two settings, you're suspecting that the other side might be hanging by a thread. And if you take some of its cells, you might break its thread. And then that one goes over the edge, and this one's over the edge, and now they're both over the edge. Now, neither eye can see. See? You got to be real careful with this. If you can't do an autograft, you're talking about a stem cell transplant. It's a whole nother lecture. It does require lifelong, strong immunosuppression, which has its own risks, and it's an option for sure. You do have other options besides stem cell transplants. You can try to make them see without stem cells. That's not easy, but a prosthetic cornea can. A prosthetic cornea, you can have better vision the next day. It doesn't care if the living parts of the cornea scar, the middle's plastic. It'll still see, as long as you don't get problems. What are the problems with a prosthetic cornea? Well, it's high risk for glaucoma, and you can't check pressure accurately. So a lot of times we're placing a tube at the time of a prosthetic cornea surgery. Even if you don't have glaucoma yet, it's going to be tied off, ready to open in the future. Another problem is you're very high risk of infection. And the tissue can break down and perforate and expulse the prosthetic. So that's the reason that the average K-Pro only is retained for 10 years. Now we found out, as I alluded in those other videos on YouTube, if you put a conjunctiva flap over the top, let it sit, let it scar, let it heal, it actually will help vascularize the cornea just beyond the plastic optic in the middle. So kind of like for those infected cases, we're providing an epi-barrier to infection, as well as bringing the immune system, boom, right to the site so that it vascularizes. Go ahead, reject this cornea. I want you to. I want the immune system here ready to defend the area so it doesn't break down. We've actually had a few cases where that's done really well. Another thing that's hard though is what if they get retroprosthetic membranes, just this weird scarring reaction inside the eye, and it can keep you laser it away, it comes back. You cut it away, it comes back. It can be a nightmare. We've had like 5 or 6 cases like that. Sometimes, not always, methotrexate injections will stop the rapidly growing cells so that the scarring cells stop growing. Oh my God. But I would never put a K-Pro on both eyes. Not anymore. I tried it on one patient, but the thing is, we're lighting a candle that might not burn forever. So why light both at once? Keep one in your pocket, keep one in the bank. And that's the rationale for just doing one, especially in a young person. We have a case that I would tell you guys about a little bit. It just goes on too long. But it's Ninja K-Pro on YouTube. It's really interesting if you want to see how intense these can get. But I just wanted to let you see what a K-Pro looks like. So on the left is what it looks like in the eye. And if you want to see what is causing that image, like what is it? There's the parts that are used to assemble it. On the top on the right is the optic. It has a little overhanging flange, which goes a little around or larger than this hole in the cornea, so it doesn't get pulled all the way through. You shove the optic through that hole in the cornea, and those rings lock it in place on the back. And that's what you're seeing, the locking ring. And infection is notorious for trying to get in at the plastic cornea junction, at that little 3 millimeter opening. It gets under the flange where not even tears can reach it, and they just start to go to town. Topical drops might be enough to keep them away, but maybe not. But I have found that if you have enough conjunctiva, and then you can pull it down without closing their lid. If it's tight, it'll close their lid. But if they have loose enough conj, you can put that over the top, let it heal for a long time, and then punch a hole in the middle. Looks a little weird, but it can preserve vision in a desperate case. Like I said, we're not going to show this case because it's on YouTube, and it goes into lots of detail.
And one quick note about limbal stem cell deficiency is I honestly think it's more common than reported. I mean, a lot of soft contact lens wearers have it, and they'll complain of this kind of photophobia, light sensitivity, irritation. I think the telltale sign is, and it's not that everybody has severe cases like maybe you've seen in this lecture, but if you stain and there's any type of that splinter, SPK superiorly kind of radiating in from the limbus, some of these kind of vortex epithelial lines, it's almost pathognomonic, I think, for limbal stem cell deficiency. So you're going to have to get out their contact lenses and their glasses patients. Maybe if you can do a scleral lens that vaults over the palisades where the stem cells are, you might be okay. But if you long-term are just going to continue to cause attrition of the stem cells and cause problems. So better to catch it early and avoid those issues.
Thank you, Ian. Yeah, it makes a lot of sense. Just be careful with I think the hardest thing is whenever we see an unhealthy cornea, we want to throw on a contact, but it's one of the cases that could burn you. It's
and
so unique.
Free load max ointment works really well to keep it, minimize the preservatives, but also helps lubricate it, but keep the inflammation under control.
Cool. Any questions before we go into glaucoma?